our next speaker is Professor Lo Ngai Nung. He is a master surgeon in our area. He has tremendous experience with primary and revision techniques. He has also trained quite a large group of surgeons in our area. So he's going to teach us some principles about periprosthetic fracture after TKA. Professor Lo?
Right. Thank you, Professor Joyce, for the introduction. Yeah. So the topic to me is periprosthetic fractures after knee replacement. And the issue we often have to face when we see such patients is this a case that we should fix or do we need to revise? So there are some principles to go by. I think we're going to see more and more of periprosthetic fractures after knee replacements in the coming years as we see more and more knee replacements being done. And these are patients who often come in after a low energy trauma, often caused by torsional or compressive force at the supracondylar region. And the risk factors invariably will be elderly patients with osteoporosis. They're often ladies with osteoporosis. Sometimes patients with corticosteroids or rheumatoid resulting in osteopenia. And of course, sometimes can happen after technical issues with notching of the anterior cortex during the index primary knee replacement. Our commonly used classification would be that by Rohraback, and he divides it into undisplaced fractures, prosthesis intact, which often can be managed by conservative casting. Displaced fractures with prosthesis intact, and that needs to be addressed by fixation or revision, and of course by fixation usually. And then lastly, type 3, where is displaced fracture with a loose implant, which has to be addressed by revision surgery. So here are some examples. I found the classification by Su et al. More practical approach to use, and you can see the picture on the bottom right, and that is a very useful guide to go by. So if you have a fracture, and invariably the fracture occurs starts off at the edge of the anterior flange of the tibia of the knee replacement, and often this is the case because of the change in modulus of elasticity between the more flexible femur and the distal supracondylar femur, which has a hard femoral component fixed to it. So under low energy stress with the change of modulus, the fracture invariably starts off from this aspect. Now the fracture runs proximally above, leaving you a nice distal fragment. Then it's very amenable to fixation. But if the fracture runs distally into the femoral condyles, then you are looking at inadequate bone for fixation, and you're looking at revision surgery. So this is, for me, the one classification to use to look at the fracture pattern. So when we see this example on the upper left, and you can see the fracture extending from the anterior flange of the implant and running proximally, and you get a sizable piece of distal femur, supracondylar, the femur to work with, and the implant is still well fixed. Then the treatment of choice to me would be fixation, locking plate fixation. If your fracture is even higher up, such that you can put a retrograde nail with locking screws, this is another option. Conversely, if your fracture pattern runs distally into the distal condyles, or if your implant is loose, or if the distal fragments are comminuted, then we are looking at revision surgery. And in this scenario, you can see that the revision is to a distal femoral replacement. So if we just remember these 3 guidelines to go by, that's interesting. And then what other reasons will we have to revise rather than do fixation? And the other one is a little bit more controversial, and it's to deal with the fact that when we compare series between fixation and primary distal femoral replacement, we will know that if we choose to fix, there are often the issues of non-union, loosening, refracture, because we're often dealing with elderly patients with osteoporosis. So we bear in mind that if we choose to fix, the papers will all say that they are more likely, you have a higher chance of further surgical procedures for fixation as compared to a one-off distal femoral replacement. So the advice would be, if you have an osteopenic patient, elderly with a high risk of non-union and who's not fit for multiple procedures, then perhaps a one-time or primary distal femoral replacement may be a better choice. We bear in mind that fixations of periprosthetic fractures is not as simple as it seems, and here is one such example where a fairly innocuous fixation done, but the fixation having driven the femoral component in the distal fragment into internal rotation, malrotation, resulting in the patella maltracking, and hence the patient needing a further revision to resolve the problem. So there are always technical issues, and you often have to send it off to your trauma colleague who is experienced in doing this periprosthetic fractures. We bear in mind too that distal femoral, periprosthetic fractures patients, as shown in these papers, 4 times higher reoperation rate after trying to fix than the revision TKR. And often the mortality at 1 year is quite significant because these are elderly patients. Often once you end up sitting in a wheelchair or losing their mobility after fixation, often have 1 grade drop in their ambulatory status, and that results in a higher 1 year mortality rate. So if I repeat again, indications when we choose to revise rather than sending off to our trauma colleagues would be very distal or comminuted fractures where we feel that we are unable to get secure distal fixation with our locking plate, or fractures associated with a loose unstable implant. Invariably, then we have to address that issue with a revision. Or when we have tried to fix and they have failed, non-union or plate loosening, then of course we have to consider now conversion to a revision. And then lastly, the fourth group, the frail elderly patient who probably only has one chance at a surgery to get her back on her feet. And here is one scenario you may want to consider a one-off distal femoral knee replacement. So if we choose to revise, then what sort of system should we be looking at to revise? And there are 3 options. We could use a distal femoral replacement system. We could use an allograft prosthetic composite, but this is less seldom done nowadays unless you have a good bone bank support. Or sometimes distal standard revision systems built on top of cones or sleeves, such as TM cones, as Dr. Vince Kelly has shown you. We bear in mind that if we choose to revise in this supracondylar periprosthetic fractures, then we still have to remember the basics of the zonal fixation system, which is a very good concept to learn in all revision system principles. And that is, we should try to get fixation in at least 2 out of 3 zones. So invariably in the periprosthetic fractures, we will have to get fixation in the diaphysis and what's left of the metaphyseal zone, considering that we were fractured in the supracondylar region. And unless we have at least a good 2 out of 3 fixations, otherwise we will not get a stable, long-lasting structural implant. So how are we going to get this zonal fixation correct? So we have at our hands a whole series of implants ranging from standard varus valgus constrained knees like LCCK to a rotating hinge type implants, and these are used when we lose the distal condyles and we lose control of the collateral ligaments. And of course, to the distal femoral replacement implants when we have to sacrifice, when we have to deal with an entire lost distal femoral segment. So these are three options we work with, and it deals with the severity of the bone loss and the level of the constraint. And the idea is that if we choose to do LCCK type or rotating hinge implant, then we have to, remembering the zonal system, we have to build this on top of a metaphyseal or diaphyseal fitting cone system, such that we can get fixation in the metaphysis and then build on top of this fixation with a standard implant with a diaphyseal locking stem. So we always try to remember, where can I anchor the prosthesis for good initial stability such that I can get then long-term biological fixation and a long-term structurally stable knee. So a distal fracture like this will require us to get fixation up in the remaining metaphysis and having a diaphyseal securing hybrid stem fixation. This is one option. So if you think carefully, if you have something distal and you're going to have to revise, you should have enough metaphyseal, diaphyseal structure left for you to secure your implant well. On the other hand, if you have a fracture that is more proximal, then you should have enough distal bone for you to fix. So actually, it's never a dilemma. Something distal, you should have enough proximal structure to revise and secure zone 1, zone 2, zone 2, zone 3 fixation. On the other hand, if you have something more proximal, then you should have enough bone for you to fix and not worry about this. So this is something similar to what Dr. Kenny showed you earlier, using TM cones or sleeves. Or if you have enough structural support and you just lose one condyle, you can attempt to fix it back for stability of the collaterals and secure the implant on the remaining bone with a long diaphyseal fixing stem and sitting on the cortical bone in the notch. Still possible. Or in a case like this, where you could then get diaphyseal fixation, metaphyseal fixation with a cone, and managing the collaterals that are loose using CCK type or rotating hinge type constraint implant. So you handle both initial stability, adequate zonal fixation, and manage the soft tissue stability this way by building up the bone loss on using a replacement system on a hyperporous structural support. And lastly, of course, in a scenario where you failed fixation, as in this case, you could see supracondylar fracture that was fixed and unfortunately went into non-union. And then after having failed the fixation, is decision made to revise. And in such a situation, then it will be a distal femoral replacement implant because you have lost too much distal femur to have a standard LCCK type or RHK type implant to rebuild. So we bear in mind that distal femoral implants only have one zone of fixation, and that's up the diaphysis. Invariably, we worry whether this will stand the test of time because of whether you get enough secure fixation. So usually the distal femoral replacements are always done in elderly patients, low demand elderly patients, and bear in mind a significant proportion often pass away after a year or so. So longevity of the knee replacement may not be such an issue. In fact, the more technical issues to concern ourselves with is to reconstruct adequate length for the extensor mechanism function, as well as ensure correct rotation such that we get at proper patellar tracking and not have extensor mechanism maltracking issues. So if we do distal femoral replacements, megaprostheses in this style of cases, the issues to consider will be restoration of length, rotational alignment, reconstruction of the extensive mechanism, and of course adequate skin cover and prevention of sepsis, which is often a significant worry when we use megaprostheses. So having laid out the principles of the zonal fixation and how we rebuild using the same principle as for revisions for periprosthetic fractures, the same principles would then apply for tibia fractures, and there is a classification for that. But the principles are very similar. If you remember your principles for the supracondylar fractures, it will apply the other way around for the tibia fractures. So the same things happen. You could choose to plate it if you think you have adequate proximal bone stock to help you support the lock plating system. The same principles happen too. You can have non-union plate structural failure from failure of union, and then obviously then having to go on to repeat surgeries. Or if you choose to reconstruct having failed the fixation or having decided that the tibia implant is loose, then it will be fixation in two zones using diaphyseal fixation with long stem extensions and metaphyseal bone loss reconstruction using hyperporous type cone systems such as the TM cone. And then lastly, very specific, very particular problem would be that of unicompartment replacement fractures. And this is very peculiar in the sense they tend to fracture through the pinhole sites after doing a uni where you have weakened, often if you're osteoporotic, you have to cut the deep slot into the bone. Then under shear stresses, they can crack right through, giving a very vertical fracture line. And this type of cases are sometimes very difficult to treat with buttress plating, and usually we would choose to revise to a total knee replacement, and we manage that vertical shear fracture often using a augment block, or we can choose to manage that using a cone system. In either way, you would get good tibia fixation. So in conclusion, I would say that to revise or to fix, fracture fixation is beneficial for preserving bone stock. And in the fitter, younger patients, we would choose to fix. Bearing in mind, we look at the X-ray, if the fracture extends proximal to the flange, the anterior flange of the knee replacement, we should have enough distal bone stock to fix. And if we have a patient that's, and we bear in mind too that if we choose to fix, we have to take the fact that there are times when we have to redo the fixation because of non-union, delayed union, malunion. And if you have a fitter younger patient who can tolerate that, that's probably the best choice. Revision TKR is invariably for the distal comminuted fractures or fractures associated with a loosened femoral component, or if they have failed the fixation, or you have a patient who is, and in this kind of cases, then we choose to revise, bearing in mind the principles of initial stability in the undamaged diaphysis metaphysis, bone loss reconstruction using hyperporous structural augments, building the knee implant, building the knee prosthesis on top of this. And then lastly, for the elderly patients with poor health, poor bone stock, with only one shot at surgery, then perhaps a distal femoral replacement, one-off, may be the best option for these patients for early weight bearing and early knee motion. Thank you.